if you don't mind, closing this presentation and allowing her to share. Hi, Meng, can you please share?
Yes, let me share my screen. Can everyone see my screen?
Yes, thank you.
Okay, thank you, Dr. Zoriba, for the introduction. So it's a great honor to be here to present part of my PhD thesis research to the audience, especially to our registry participants. The project that I'm going to present is about psychological status of LQDS patients with and without implantable cardioverter defibrillators, or ICD. I'll start with, let me see. Okay. Sorry, okay, great, it works. So I'll start with a brief background of this topic. So as mentioned before, ICD is an important treatment option for long QT syndrome, as well as many other cardiac disease. However, some qualitative studies in the general ICD population reported that some patients may develop adverse psychological response to the device, such as shock-related fear, increased disease awareness, body image concerns, etc., with depression and anxiety being the most frequently reported mood disturbance. On the other hand, positive responses to the device, such as perception of greater security and protection, and feeling grateful to have gained this extra time of life, have also been reported. So the findings from the qualitative studies are kind of mixed. Population-based studies of ICD and psychological outcomes primarily focused on heart failure patients, and their findings have been inconclusive. To our knowledge, no studies have examined the relationship of ICDs and psychological outcomes in LQDS patients who have very different characteristics compared to heart failure patients, and thus may have distinct psychological response to the device. We want to study psychological outcomes, not only because it is by itself an important part of our well-being, but also because it may affect patients' cardiac prognosis. The research from our group have shown that in LQDS patients, acute emotional stress may trigger arrhythmic events. And studies in other cardiac populations have associated depression and anxiety with a higher long-term risk of ventricular arrhythmia and sudden cardiac death. By contrast, positive psychological features, such as optimism and meaning in life, have been associated with a lower long-term risk of cardiovascular disease and overall mortality. And interestingly, this association was independent from depression and anxiety, indicating that those positive psychological features are not simply a flip side of depression and anxiety. They may play a unique role in the health of our heart. So, however, despite the importance of the positive psychological features, no studies have examined the relationship of ICDs with them. To address these research gaps and also better understand the relationship between ICDs and psychological outcomes in LQDS patients, we performed this cross-sectional study aimed to examine associations of ICDs with depression, anxiety, optimism, and meaning in life in LQDS patients. We also have an exploratory aim, which is to identify correlates of each psychological outcome in ICD patients and separately in non-ICD patients. Findings from this exploratory aim may help us generate hypotheses regarding risk factors of developing psychological dysfunction. Study design. So this is a survey-based cross-sectional study, meaning that ICD status and psychological outcomes were measured at the same time, which is at the time of the survey. And to be included in the study, participants need to qualify for LQDS diagnosis by either QTC or genotype, aged 18 to 75 years of age, and remained active follow-up with the registry. And this inclusion criteria resulted in a total of 873 participants and of them, 283 were ICD patients. And we sent survey to all eligible participants by either RightCap, which is an online survey app, or by mailing. And the survey contains several validated self-administrated instruments to measure psychological outcomes, including depression, anxiety, optimism, and meaning in life. So the depression was measured by an instrument called Back Depression Inventory 2, which is a 21-item scale that measures depression symptoms during the past 2 weeks. And here are some example items. Each item has 4 response categories ranging from not present to severe. Like for example, the response options for sadness ranges from I do not feel sad to I am so sad and happy that I cannot stand it. State anxiety was measured by 20 items in the scale of state and trait anxiety inventory, which measures anxiety-related feelings right now or at this moment. And here are some example items with the response categories. So trait anxiety was measured by the same instrument. There are 20 items that measure how people generally feel. So again, there are some examples and the response categories indicate the frequency of each feeling. So optimism was measured by life orientation test revised. Here, the slide shows the full scale. It measures generalized expectations for positive versus negative outcomes. And the response categories indicate the degree of agreement to each statement. And meaning in life was measured by the presence of meaning subscale of the meaning in life questionnaire. It has 5 items that measures a sense of life purpose and significance. And the response categories indicates the degree of agreement to each statement. So for all psychological outcomes, a total score can be calculated by summing up the item-specific score, and higher scores indicate a higher level of the corresponding psychological outcome. In addition to these psychological outcomes, the survey also collected data on updated demographic and socioeconomic status, cardiac events, history of psychological disorders, and medications. For ICD patients, we ask them to complete an additional questionnaire that measures their level of concern of the device. We also created 4 brief items as shown here to assess their positive ICD attitude. And here is the ICD concern questionnaire. It's listed possible concerns of the device and ask the participants to rate the degree of concern for each item. So we sent out surveys to all eligible participants, and we got responses from 331 patients with a response rate of 38%. And this table shows the characteristics of responders, both overall and by ICD status. We can see that the mean age at the survey was about 51 years old, and about 70% were females. As expected, ICD patients had overall higher LQDS risk profile than non-ICD patients, such as a longer QTC and a higher prevalence of arrhythmic event history. And notably, ICD patients also had a higher prevalence of psychological disease history and severe comorbidities, and were more likely to use psychiatric medications at the time of the survey. So now let's take a look at the analysis we performed for our mean study aim. We compared the level of psychological outcome, which was measured by a continuous score between ICD patients and non-ICD patients. Given that the 2 groups were inherently different in terms of demographic and clinical factors, we further controlled for these factors in our analysis to tease out the impact of ICDs from the impact of these other factors on psychological outcomes. And this is achieved by statistical modeling. So here is what we found for crude comparisons. Let me first work through this graph. So the x-axis indicates the 5 different psychological outcomes, and the corresponding data points are difference in scale scores between ICD and non-ICD patients. And here we use non-ICD patients as the reference. And the right horizontal line is a mark of 0 difference. So any data points above this right line suggests that ICD patients had a higher score than non-ICD patients. And any points below this right line indicate that ICD patients had a lower score than non-ICD patients. And the cuffed in intervals, the arrow bars are cuffed in intervals, and an interval that does not cross the 0 line indicate a statistically significant difference. So as can be seen here, in crude comparisons, ICD patients had a trend of higher depression and anxiety and a lower level of optimism and meaning in life compared to non-ICD patients. And the difference for trait anxiety and optimism reached statistical significance. But again, this is only a simple crude comparison without any adjustment. So now let's add adjusted results to this figure. So the dark blue data points represent results after controlling for demographic and clinical factors. And we can see that after this adjustment, the data points became closer to the 0 line, and there were no longer significant differences in any of the psychological outcomes between ICD and non-ICD patients. So together, this suggests that the seemingly worse psychological outcomes in ICD patients observed in crude comparisons are likely better explained by confounding by other factors rather than by the ICD device per se. And after appropriate adjustments or controlling for other factors, there was no significant associations between ICD and psychological outcomes. We then further explored the impact of ICD shocks. To do this, we further divide ICD patients into 2 groups, patients with a history of shocks and patients without history of shocks. And we compared each of the 2 groups to patients who never had an ICD implanted. And here we only focus on appropriate ICD shocks because very few patients in our study sample had inappropriate ICD shocks. And here is what we found for shocks. So the blue data points represent patients without a history of shocks, and orange data points represent patients with a history of shocks. And because all the confidence intervals cross this 0 line, so neither ICD patients with shocks nor ICD patients without shocks had a significant difference in any psychological outcomes compared to non-ICD patients. But if we ignore the confidence interval for now and only look at the point estimate, then the orange data points suggest that there may be a trend of higher level of anxiety and depression and lower level of optimism and meaning in life in patients with a history of shocks compared to non-ICD patients. So these are all the findings for our main study aims. Now let's take a look at our exploratory aim. In the analysis of our exploratory aims, we wanted to see among this list of candidate variables, which ones are consistently associated with different psychological outcomes. In non-ICD patients, we examined age, sex, marital status, LQS-related clinical factors, self-reported history of psychological disease, current psychiatric medication use, and presence of severe comorbidities. In ICD patients, we additionally examined years since ICD implantation, number of appropriate shocks, ICD concern score, and positive ICD attitude score. We used a similar statistical modeling approach, and we found that among non-ICD patients, history of aborted cardiac arrest or syncope prior to the survey was the most consistent correlate associated with all psychological outcomes except for state anxiety. And in ICD patients, we found that ICD concern score was the most consistent correlate associated with all outcomes except for optimism, followed by number of appropriate ICD shocks, which was associated 3 of the 5 psychological outcomes. Right. So now let's have a summary of the key findings of this project. In this cross-sectional study of long QT syndrome patients, there were no significant associations of ICDs with any of the psychological outcomes examined. And there was also no significant difference in outcomes between non-ICD patients, ICD patients who had not experienced shocks, and ICD patients who had experienced shocks. Here, I would like to note that the majority of patients with a history of shocks had remote shocks, occurred at least 1 year prior to the time of the survey. And also the majority of participants only had a small number of shocks, rarely larger than 5, mostly just 1 or 2. Since the timing of the shock and the cumulative number of shock can affect patients' psychological response to the device, this may help explain the null findings, like why we didn't find a difference. And also we only have 24 ICD patients that experienced the shock. So the small sample size also limit our ability to detect a difference. Regarding consistent correlates of psychological outcomes, for non-ICD patients, we found that history of aborted cardiac arrest or syncope prior to the survey was the most consistent correlate. And for ICD patients, concerns about ICD followed by appropriate ICD shocks were the most consistent correlate. And lastly, I would like to briefly discuss the clinical implications of the study findings and future directions. So first of all, findings from our study do not support that ICDs have adverse psychological impact. This is a positive message for LTS patients because ICD is an important treatment option. However, these findings are not to diminish the importance of psychological care of ICD patients. ICD patients are indeed more often sicker than non-ICD patients, so they may be at higher risk of psychological dysfunctioning. And also, each individual may have their unique perception of the device. So their psychological care, psychological health need to be closely monitored and treated if needed. So correlates of psychological outcomes can provide information to help us generate hypotheses regarding risk factors of developing psychological dysfunction. And based on our findings, patients with a history of aborted cardiac arrest or syncope and ICD shocks, as well as and more ICD shocks, as well as those that had a higher level of concern of the ICD device, may at a higher risk. I also want to note that this is only a cross-sectional study with ICD status and psychological outcomes measured at the same time. So it cannot establish temporality or prove cause and effect. And future longitudinal studies are needed to further examine the impact of ICDs on mental health and identify risk factors of developing psychological dysfunction. So, and I would like to thank my thesis committee. This is the third aim of my thesis work. I would like to thank my chairs, Dr. Rich, Dr. Zoreba, and Dr. Reis, who is a professor of psychology, and Dr. Sablaki and Dr. Peterson, who are our statistical experts. I also want to thank our wonderful colleagues at Clinical Cardiovascular Research Center and Department of Public Health Science. And most importantly, our long QT syndrome registry participants. This work would not be possible without your participation. And I would like to end my presentation with a graphic summary of the key findings of this project. Thank you.